So we've got two speakers today. We've got Dr. Richard Martin, who is a consultant clinical geneticist from Newcastle, with over 5 years of experience with a main interest in inherited cancer genetics, and Helen, who you will know and have seen online before, who is a registered genetics counsellor with, she told me to say 20 years plus, but I don't know how that is possible, experience. More recently, Helen has been working as the regional Northeastern Yorkshire GMS workforce development and educational lead, which is a mouthful and no idea how you fit that on your badge, Helen. So without further ado, I'm going to hand over to our speakers. As I say, use the chat box to ask any questions, but I've been told that there will be an opportunity for hands to be raised later in the presentation. So yeah, over to you guys.
Thank you very much, Nikki. Nice to be able to speak to you today. Richard Martin. I'm going to start off and then pass over to Helen after about 20 minutes or so. So, firstly, inherited cancer predisposition. Like a lot of messages today, it can be simple, but there's lots of complexities to it as well. I guess when people talk about inherited cancer, we're normally meaning a dominant, autosomal dominant, or dominantly acting gene alteration that's passed on in a family that leads to a high risk of certain cancers during that person's lifetime. And these are genes that we all carry. They normally have protective roles in our cells, which are constantly dividing, repairing themselves. But when one of them is essentially faulty and not working, then that particular person is more likely to develop certain cancers, depending on lots of factors, but certainly principally the gene in question. This concept of penetrance is something very important in genetics, whereby quite a number of genetic conditions, as I'll show you on the next slide, aren't fully penetrant, meaning that actually you can have the genetic predisposition, the genotype or the genetic background, but you don't go on to develop medical evidence of that condition, termed a phenotype essentially. So the family tree in the middle there could well represent a BRCA2 family with, let's say, the people coloured in having a BRCA2 related cancer like breast, ovarian or prostate cancer. If those three people shaded in green all share a BRCA2 gene alteration, then the intervening gentleman here, if you can see my cursor, must also share the BRCA2 gene alteration, but he, let's say, he doesn't have a cancer, so that's a good example of non-penetrance. Particularly as a man, it's very possible to share a BRCA1 or BRCA2 gene alteration in your DNA, but never go on to develop a related medical problem. As I say, almost always these genes are dominantly inherited, meaning that there's essentially a 50-50 chance that the gene is passed on to the next generation. Cancer is very complex, and the term inherited cancer you can talk about, I guess, till the cows come home, because it's very difficult to define in its entirety.
They're recording it, so I'll just confidential with you.
So breast cancer, for example, is a very common condition, and that's one of the complexities here. We know of a number of risk factors for breast cancer: female sex, increasing age, hormonal risk factors, and actually your underlying inherited genetic predisposition or makeup is only one of such factors, and is never the whole story. Over on the left-hand side of the screen here, you've got examples of conditions that we understand to be fully penetrant. So, for example, Huntington's disease, very well-known dominant condition in families, if you have the genotype, if you have the gene alteration that causes Huntington's, you will always develop signs of Huntington's during your lifetime, assuming you live into old age. This is so that is an example of a fully penetrant condition. But actually, all the genes really that we think about in the cancer world, certainly for today's purposes, are less than fully penetrant. Even Li-Fraumeni syndrome, very well known for causing a very high risk of cancer during a person's lifetime, including childhood cancers. But not everyone with the Li-Fraumeni TP53 gene alteration will get a related cancer. BRCA1, very highly penetrant in women. Maybe 80 or 90% of women who carry a BRCA1 gene alteration may develop either breast or ovarian cancer, but that means there's a proportion who won't. And certainly if you're a man with BRCA1, we see very low cancer penetrance for BRCA1 in males. Their cancer risk estimates aren't dramatically increased at all over and above the general population risk. We learned about these big hitters in the genetic world many years ago, but actually, like all of medicine, there's a lot of complexity down this end of the scale where there is more common variation in genes that has a less dramatic effect, and those can be single genes that we'll come to, like CHEK2 and ATM, that confer something of an inherited risk, but not to the same extent as BRCA1. And then SNP, single nucleotide polymorphisms, essentially mean just single base DNA changes that are quite common on their own. We all have a lot of genetic noise, genetic background variation, whatever you call it. And actually these also contribute to breast cancer risk and risk of lots of other common conditions. So we've got your dominantly acting highly penetrant genes over here that contribute to breast cancer risk, but down here we know that actually things are a lot more complex, and that's illustrated in the testing that we do in families, in that sometimes you can have a very strong family history of breast cancer. We don't find anything in the genes up at this end, and we suppose actually the presentation is more governed by more complex genetic factors interacting with environmental and other factors that we can't fully tease out. And that's nearly always the case when a cancer happens. We're rarely left with a very clear explanation of why a particular person developed a particular cancer at a particular point in time. Causation is very complex. So genetics is difficult in this situation because actually genetic testing actually fairly rarely gives us the answer, or overall is much less likely to give us a clear answer, even when you meet criteria for genetic testing on the NHS in a breast cancer setting. Even when the family history is particularly strong, most often we don't find anything on the genetic test that we can currently do. Doesn't mean it's not genetic, doesn't mean it's not familial, doesn't mean there's not an inherited contribution. It just means we can't put our finger on a single gene alteration that is strongly linked. As we've known for a long time, a higher familial risk can still be inferred in that family, and they can be offered, for example, moderate or high risk screening based on their family history alone, dependent on a individualized risk assessment, most often these days carried out by this nationally approved program called CanRisk, which is here. Most of you have probably heard of this. It is a really good resource, has limitations, but it's a really good way of plugging a lady either without cancer or with one breast cancer in and taking certain demographic details on board, certain reproductive and hormonal risk factors on board. It can take account of her family history. It can also take account of genetic testing in her or her family. And essentially it spits out a risk figure for that lady developing a breast cancer in the future, or developing a contralateral breast cancer in the future if she's already had one breast primary cancer. So that's a useful resource that we use in genetics to try to pull together some of the information that we gather on families and help with risk stratification and counselling. So the nuts and bolts of genetic testing, let me take you through that. The test that we'll focus on is the gene panel test here, listed under germline DNA based testing. Just to flag that, a bit like radiology testing, that the term genetic testing can cover a wide variety of different things, and some of these are in the breast cancer world are listed below. For example, you can do tests on tumor DNA. Because tumor contains genetic changes not found in the rest of a person's body, essentially. An example of that is an oncotype test to guide chemotherapy. So it's a tumor DNA-based test. You can also sequence genes in tumors, and certainly that's done in the ovarian and prostate cancer world, where actually biopsy of the tumor can be sent for genetic testing, looking for knockout or loss of BRCA1 or BRCA2 to guide PARP inhibition. So those are examples of genetic tests done on tumor DNA. When we're talking about germline DNA, that's the DNA that can be passed on in families. We generally obtain a sample of germline DNA, the DNA a person was born with, by taking a blood DNA sample, just a straightforward purple EDTA tube of their blood, and DNA can be stored by the genetics laboratory and used for, again, a variety of different tests. One that will increase in utility across the NHS, I'm sure, over the next decade is what we call pharmacogenomic testing for common genetic variation in germline DNA, which can influence prescription of medication, how we handle medication, what dose we might need, who might have a bad, adverse or non-effectual reaction to certain medications. So that's certainly a good window into the concept of precision personalized medicine at a very early stage of any adoption at an NHS level. This is the test that probably a lot of you will have familiarity with and may well have requested, and the 7-gene diagnostic panel test. When you've got a woman or man with breast cancer who meets certain NHS criteria that I'll show you, they may well be eligible for testing of a blood DNA sample looking for an inherited germline gene alteration in one of these 7 genes, and we'll talk about the utility of that shortly. Sometimes a woman with breast cancer may turn up in a family where we already know there's a CHEK2 variant or there's a BRCA1 variant. The best test for that woman, if she is untested, is potentially just to test her for the specific familial variant test. Let's not take 3 or 4 months and more money and resource to do to necessarily test all of her genes, but it may be appropriate to target testing to the familial variant that's known already in that family. That's termed a predictive test if we then, in clinical genetics, this would be see an unaffected relative who is aware of her family history of breast or ovarian cancer and the finding of one of these gene alterations. That woman may choose to have a predictive specific familial variant test to guide future risk estimates and screening preventative options for her. Just to, I guess, let you know where we are at the minute with NHS-based genetic testing, and how this is really to be seen as part of a continuum, whereby certainly over 10 years ago, we were only testing a relatively small number of families when there was a really high chance of finding something. So women who were very young, or women with triple negative breast cancer at a young age, or lots of ovarian cancer, or very strong family histories. But as genetic testing has got cheaper and more affordable, more readily available, more useful, thresholds have come down and currently are as defined in the National Genomics Test Directory, which tests women at a much lower level of risk than a 20% chance of finding something important. In the future, we may well test everyone with breast cancer, or certainly everyone potentially under 65 or 70 or 75. There may be utility in putting an absolute upper age limit on things, but I don't doubt we'll continue to move forward and closer to this scenario in the future. The scope of the genes that we're testing has also changed. You'll know that BRCA1 and BRCA2 were discovered in and around 30 years ago. and these other genes have been discovered more recently, essentially. And so the current NHS breast cancer panel includes 7 genes in total. That will be added to in the future alongside this concept of somehow quantifying a woman's polygenic risk. So lots of other small DNA-based changes that aren't that important on their own, but in some way add together to influence risk, and that might help risk stratify. All of these things are just risk stratification methods and trying to add to ways that we already stratify risk. And you can stratify risk based on BMI, on alcohol intake, on family history alone, on breast density. Clearly, to do this to the best possible standard, you need a really good program to merge all that data together. So I guess we're closer to that now than we were, but there's a long way still to go. I guess the thing that hasn't probably moved along as quickly as we all might like is the turnaround time, and that's purely based on NHS generally clinical scientist resource. More and more women and men are eligible for testing now. So current NHS labs are spitting out many more breast cancer panel tests than they were 10 years ago. But there are more genes to interpret. There's lots of variation in those genes. Although the technology is there still needs to be a human scientist checking and curating variants in these genes, and it's probably their time that's most critical in bringing this down. But that also depends on trained expert scientists. It's not just a money staffing problem. There's a staff training issue to be solved as well. In the private sphere, if money was no option, the test could certainly be done in a few weeks. There's no technological reason why it couldn't be done in a few weeks. It's all really about resource, and primarily human resource. You can Google the National Genomics Test Directory, and this is updated a couple of times per year. It's been out for the last 3 or 4 years. It defines the genetic tests that can be done and by whom in NHS England. You'll have these slides afterwards, of course, on the recording, so you can have a look in a bit more detail. The main the test codes are all coded, or the test panels are all coded. The panel you'll be most interested in is called R208, and the criteria to test a living person with breast or ovarian cancer for this gene panel are listed as below, and that will be familiar to a lot of you. And these criteria generally relax as time goes on, and some of these catchment areas have got broader. So year on year, more patients are eligible for testing. And certainly if you meet criteria 1, A, B, C, or D, these are all definable in your breast clinic. We are certainly encouraging breast teams to take testing forward directly in and around diagnosis to help guide things from there. Some of these other categories, we generally recommend in our region at least some clinical genetics involvement, because confirmation of family history in more detail is required. Those are the genes tested. Some additional things to note: your patient may be eligible for an additional TP53 gene test in addition to these 7 genes if certain age criteria, less than or equal to 30 years old at diagnosis, or under 35 if they're HER2 positive. Generally, it's just clinical genetics or oncology who can request this test. To note, there may be a variant already known in the family of one of these genes, in which case don't do the whole panel, but talk to genetics. There might be alternative diagnosis that's likely based on very rare syndromic features. This would be very small print, but just to flag. And finally, there is an additional test code that can be requested by oncologists, which are a little bit broader than these, and are based around a patient's staging and presentation of breast cancer to allow treatment with PARP inhibitor if eligible. A bit about the utility before I hand over to Helen. So what's the point of genetic testing in breast cancer? I guess really it's all about defining well, historically at least, it was all about defining the risk or chance of a new future breast primary cancer, principally because that can influence the need for often contralateral or ipsilateral risk reduction of breast tissue. And that may be eligible if genetic testing helps us compute a high risk for a woman. And that could feed into their treatment pathway, which is why that these results are often needed as close to upfront as possible. In the last few years, then, having a BRCA gene alteration may allow an oncologist to use a PARP inhibitor. So that's one additional thing. So some of this needs to be done fairly promptly. In the longer term, though, there's utility of results in the longer term to guide screening or more longer term risk reduction, including for ovarian cancer, and very importantly, to help us best look after other family members. So things are relatively straightforward in some senses. If we can find something in one of these very well-defined, very high-risk genes, we can give a lady a risk that is generally in a very high-risk group in terms of a future new breast cancer, and that may allow additional risk reduction to be considered at least. But remember, things are complex because we often don't find one of these gene alterations, and we're left in a more uncertain scenario depending on the strength of the family history, or if we find something in a more moderate risk gene, breast cancer being complex and multifactorial in families that don't have BRCA1, BRCA2, or PALB2, but still have a strong family history, things are quite complex. Remembering CAN risk can take this into account. So our very high risk genes, as above there, and the ones in green termed more high moderate in terms of their breast cancer risks. These four also linked to a risk of ovarian cancer, with BRCA1 being by far the highest risk ovarian cancer gene. There are some links with other cancers. The main screening that's offered at the minute in terms of non-breast, non-ovarian issues is with BRCA2 and male prostate cancer PSA checks. I've included a link here if you want to read more about each individual gene and current recommendations and risk stratification. This produced by the UK Cancer Genetics Group. There are some curated leaflets and guidelines on a gene by gene basis. So allowing, if we find a gene alteration, basically, so if we're talking about inherited cancer and we do find something specific in an inherited sense in a person's DNA, that can allow early breast screening for them and their family. It can allow consideration of further surgery, chemoprophylaxis in terms of tamoxifen, letrozole, maybe an additional thought. Ovarian, you'll see the lack of options really with ovarian risk management. Screening doesn't work, hasn't been proven to work, and it isn't recommended in this country. Certainly, we hope to that will change, perhaps with better non-invasive screening methods going forward. But at the minute, it's an all or nothing approach really, with risk reducing surgery at an appropriate age, again gene by gene. Last two slides, I think. I suppose this illustrates how the 7-gene panel can help risk stratify a woman's contralateral breast cancer risk, if this is the same woman in each pedigree presenting age 35 with breast cancer. You can see when I've given her a different family history, depends on the ages of these people being affected with breast cancer, of course. If I've given her a CHEK2 variant, if I've given her a BRCA1 variant, I've listed here some approximate contralateral risk figures. This is a 35-year-old. Let's say she's expected to live to 80 years of age, or that's what we normally use. We need to assume obviously she's had a good prognosis breast cancer here to be thinking about these issues. But these sorts of groups are where we would put her, often depending on strong family history, CHEK2, BRCA1, and it's really both extremes are quite easy to deal with. BRCA1, all options are on the table. No family history, no genetic alteration. It's quite clear often how to manage this woman. It's these ones in the middle that actually probably everyone has a different view on, and centres may be managing in slightly different ways in and around this boundary that we tend to consider between moderate and high risk in this context of a second contralateral breast cancer. I think more guidelines and more robust national steer really is needed to ensure consistency of care across NHS England for these groups. This is the last slide. I haven't time to talk too much about it, but I wanted to highlight, I think, some of the experiences that I've had and how there is so much potential for confusion here amongst healthcare professionals and patients in the language we use and what different people mean by that language. The fact that patients understandably often understand that a normal gene panel test doesn't mean it's not genetic. If that lady has had very early onset breast cancer and a strong family history, undoubtedly there will be inherited genetic factors contributing. It just means we haven't found them. The concept of risk figures and how well they're understood, even using the word risk is loaded as opposed to using the word chance, the language we use and how that can be taken in different ways by a patient. Defining risk groups and what they're fit for and how people at times can use these in different ways, depending on whether they're talking about screening or indications for bilateral risk-reducing surgery. Getting a good quality information and choice out there about risk reduction, and there can be a misconception that actually finding a very high risk gene alteration means that actually almost a reflex bilateral mastectomy should be done or should be strongly offered to a woman. I don't think that there's evidence that should be the case. Certainly we've had ladies with advanced ovarian cancer come through a joint clinic in our region expecting to have bilateral risk-reducing breast surgery, and if they've got a guarded prognosis, often at an older age because of ovarian cancer treated just 1 year ago, not a patient that it would be appropriate to be considering bilateral risk-reducing mastectomies on when actually very good quality annual breast screening is available for this group. I think there's a danger of over-interpreting the moderate risk genes and rushing to extra surgery and panic in lots of women who that may not be the best approach in. Talking to women about risk, there's often a confusion between the risks we're talking about in cancer genetics, inherited cancer genetics are really always about the risk of a new primary cancer, a contralateral breast cancer in the future, or an ovarian cancer. But you can imagine that sometimes that's confused, and when you talk to the patient more, they're actually thinking or wondering, does this feed into the chances of my cancer recurring or coming back? And that does often cause confusion and warrant some careful care. Genetic testing is complex. Just to finish on, the test is relatively straightforward to organise, but takes a long time at a laboratory level, not least because we all have a great deal of genetic variation, and sometimes we don't know what that means. We find things in people's genes and we just don't know if they're important or not, and we only will with the passage of time. I will flick on one more slide and pass over to my colleague Helen. Thank you, Helen.
Thank you. Thanks, Richard. That was a really, really helpful overview, and I think leads nicely onto what I'm going to talk about. So the questions that when we were asked to do an inherited breast cancer session, we asked specifically what the request was and what questions we were trying to answer. And the two questions that were on the slide were questions that were posed. So, and these are the ones that I'm going to attempt to address in my bit of the session. So how do we encourage families to test, and what are the health and social implications to being tested and being positive? So for the first question, that's relatively easy to answer. So we don't encourage families to test. It's really important that the decision to be tested is an informed decision and an informed choice, and that the patient wants to know. As part of that, we need to give balanced information through detailed consent discussions, and I think this is what I'm going to focus the majority of my presentation on. But before we do, I just want to pause and clarify something that Richard has already touched on, which is the distinction between diagnostic and predictive testing. So in the context of inherited breast cancer, for those in mainstream, so those of you that have joined on the call, When we're talking about genetic testing, we're very much talking in the context of a diagnostic test. So a patient who may have had breast cancer, using Richard's example at the age of 35, has siblings and parents and aunts and uncles. The testing that you are considering in clinic is very much a diagnostic decision. So it's testing of the patient that is labelled here with a red arrow. The testing of predictive testing, of testing unaffected relatives that Richard touched on, is something that clinical genetics have been dealing with for many, many years and will continue to do so going forward. And that's looking at testing for families that are circled here in the green colour. So just to make that distinction before we go any further. So in terms of that second question about what are the health and social implications of being tested and being positive, so it is a bit of a busy slide, but I will break this down as we go through. So to structure the answer to this question, I'm going to use a resource which is known as the record of discussion, and that's shown on the right hand side of the screen. And this is a resource that is widely available. You can either Google it or use the QR code that's shown on the screen. And essentially it has been designed to support the consent conversation when whole genome sequencing, or WGS, is offered, and that's generally offered in the context outside of breast cancer. So we're not talking about WGS testing here, but I think this record of discussion is a real gold standard of the conversation that we would hope would majority take place when people are being offered genetic testing. And therefore, I think over the next few slides, it'll help me to structure the answer to that question that we've posed, and also help support you in terms of having those conversations with patients going forward. So if we take each point bit by bit, so these are the sections that are given on the form that are listed on the left-hand side, and we're just going to go through those one by one. So firstly, family and wider implications of genetic testing. So this paragraph reads, the results of my tests have implications for me and members of my family. I understand that my results may also be used to help healthcare of members of my family and others nationally and internationally. This could be done in discussion with me or through the process that not personally identifies me. So I think first and foremost, the main implications for patients are often the emotional implications. So using the family history that's given on the right-hand side, where there's a new diagnosis in a woman, she's got a previous history of having a mother affected and now deceased. Suddenly bringing into the conversation the idea that genetic testing is going to be offered can bring up a whole host of emotions. This can often be at a very difficult time when she's just receiving a diagnosis, and actually opening up that conversation can open up a can of worms. It's really important to support and explore patients' feelings around this. More often than not, patients will report feelings about genetic guilt and genetic burden, and it's important that we reinforce to people that they have no control over their genomics or genetics, or what the factors that they've inherited. And it's important that we explore the fact that not all patients will want testing, and that can be particularly difficult when maybe there's siblings or unaffected relatives who are maybe putting on pressure to have testing. And again, that can bring with it lots of emotions. In addition to the emotional implications that testing can bring, there are also financial implications, for example, with genetics and insurance. So this is very much a whistle-stop tour. There is more information available on the QR code by the Association of British Insurers. But essentially with genomics and insurance, companies there is a voluntary code within the UK, which most major providers adhere to, which is that genetic tests are not requested, that information isn't requested when applying for insurance. More relevant though, insurance companies, as you are probably all aware, can ask about family history. So in this scenario, they would be asking about relatives who'd had cancers, but it is something just to bear in mind with patients that in the future this may have implications. Also with employment, so some employers may ask for genetic results, although unless the result is going to mean that that individual is putting anybody else in danger. In another example, for example, in inherited cardiac conditions with maybe a long distance lorry driver, they would need to disclose that result to their employer. However, in oncology, and particularly with breast cancer, that's unlikely to be the case. But all genetic conditions are covered by the Disability at Work Act to make sure that people can get access to appointments and to treatment that they need outside of work. But it's just something that is worthwhile maybe being aware of. In terms of uncertainty, I think Richard's already covered a lot of this, and I think again it's more not necessarily that you have to go over in lots of detail with patients, but it's really important that we reinforce to patients when they're having testing that this is unlikely to give them very definite answers. Even those who receive a definite answer at the time, results classification can change over time. It is rare, but it can happen. So it's really important when we're offering patients testing that we're just very clear with them, that we don't raise their anticipation of having a very definite black and white answer that is going to be very clear cut. Even those with a positive result, we don't know, and even if we know that they have got a very high chance of a contralateral breast cancer, we don't know when or if they will develop that. As Richard said right at the beginning, nothing is ever 100% with genomics. And so again, it's not to necessarily go over that in a lot of detail with patients, but it's just giving patients that kind of knowledge from the outset that this isn't necessarily going to be an absolutely clear-cut scenario. And in most scenarios, there's some uncertainty that we'll give with that. So in the example given on the screen, if a positive result is found in that female who's had breast cancer, there may be uncertainty still again in terms of if and when she may ever develop cancer again. Also, in terms of if she has children, then we wouldn't necessarily offer testing to them until they're over the age of 18. It may be that her relatives decide not to have testing, even though she, is maybe found to carry something. And so it can sometimes be difficult for patients to live with the fact that they've got this knowledge, but others haven't taken that up. In a negative result, again, like Richard said, there could still be family factors that are affecting the risk, and so they may still be needed to, we may still need to explore that through a referral through clinical genetics to assess the family history. And obviously, there's always the possibility of a variant of unknown significance where we're still left scratching our head at the variant that we found as to whether it is or isn't contributing to the family history picture. And we have to be very clear with patients that in a VUS scenario, we would not offer testing to those that are unaffected. And that can often be very difficult for patients to accept and understand. In cases such as this, if patients are struggling to accept that, then it's really important to seek support from the genetic counselling team at your local genetic service. Unexpected information is also considered on the form, and in the example of carrying out breast cancer panels, this isn't so relevant, but in other areas we may receive results which indicate, for example, that if they're testing alongside their children, then it may reveal non-paternity. So as I say, this element is much less likely to occur within the context of breast cancer testing, but it may well still reveal risk of susceptibility to other cancers, for example, ovarian cancer. So it's just about making sure, again, you don't have to go into lots of detail, but just explaining to patients that when they do have this testing, we're not just testing specifically for breast cancer. Often these inherited tendencies come with other risks like the ovarian cancer, like prostate cancer risk, and it may be things that they hadn't necessarily considered. And all of this is very much about cushioning that patient further down the line so that when they do get information that has revealed unexpected information, they're already aware that something like this has the potential for cropping up. Into DNA and data storage. So we routinely store DNA and data for an unlimited period. And again, this can often take patients by surprise that we store both their DNA and their data. Again, you don't need to go into everything. It's just to make patients aware that that happens. One of the things that is key is that this will form part of their health records. However, it won't form part of their relatives' records. So confidentiality is obviously very key within genetics. And so until that patient has decided to share it with their relatives, we wouldn't actively routinely go out and share that with relatives. Although if we did find something that had implications for their relatives, then we would work with that patient to encourage them as far as possible to share that information with their relatives, because obviously it may have implications for screening. Finally, I mentioned at the beginning that this the recorded discussion has multiple pages, so it actually has 3 pages. The second one goes into discussions around the National Genomic Research Library, and the third page is actually a consent page. But pages 2 and 3 are not relevant in this context, so it may well be in future that they may be, but at the moment where we are doing just specific panel testing, we're not including that data within the National Research Library, so you can ignore pages 2 or 3. So just to reiterate, it's just page 1 where it's got that record of discussion, which might be helpful for you going forward as a resource. So as I mentioned at the start of my section, the choice to pursue genetic testing is a deeply personal one, and this can really be challenged, particularly at the moment where we're moving towards genetics informing treatment options, but it's still, the decision must still be rooted in the patient's choice, regardless of what relatives or professionals are feeling about the situation. And it's important for us to stay as professionals as neutral as possible. And obviously this can be very difficult when it's conflicting with family members, and so it may well be that patients may need that additional support, and your clinical genetics teams have got many decades of experience of dealing with these difficult scenarios. They are rare, but if they do crop up, then please do reach out, because we can help in those scenarios, both support the professionals and also maybe in having conversations with the patient as well. So again, it's important to stay neutral and allow the patient to make their own decision, and as long as it's an informed decision, so as long as they understand their choice to not have testing might have implications for, meaning that their relatives can't access screening or management options, and it's limiting in that aspect, as long as that's an informed decision, then you've done your job, and ultimately it's down to the patient themselves to make that decision. So in terms of being positive, so when patients do, on the rare instances they test positive, I just wanted to share a few of my reflections of working as a genetic counsellor, and some of the comments that I put on the slide are ones that I regularly have heard throughout my clinical practice. So we've covered many of the implications, but what I would say is that the vast majorities of people, their main agenda is very much around their children's, and if they haven't got children, it's generally around their siblings. This is often a lot of information to learn at what is potentially a very difficult time. So although I more often might see ladies coming in, you know, in the scenario where they've had a new diagnosis and they're going through genetic testing and they feel very keen to know this information, actually when that kind of worms is open, it can be very difficult to deal with, and that's on top of being on a difficult healthcare journey at that time. So it you know, often, you know, they might need that additional support, and again, your genetic counselling team will be well versed in that, either to support you to support the patient, or if things are becoming difficult, then for the genetic counselling team to support the patient directly. For some, a positive result isn't necessarily a bad thing. I think one of my most difficult results I've ever given was actually a negative result, when the family history had a very strong family history, and for many years had been wanting a definitive answer of what's going on. So I always keep that in the back of my mind, that for others a positive result isn't necessarily a bad thing. It can provide clarity, it can provide access to management options and also family planning. The certainty of your result can be desired, but actually when that comes, it can be difficult for families to realise actually there's a lot of uncertainty that's still going to go with that. So if they've got young children, they might have to wait another decade or so for us to even offer testing to their children, and their children may choose not to have that. So there can often be a lot of difficult emotions as well going around that, even with the certainty of a BRCA1 result or whatever the result is. I'm remembering as well that with difficult cases, I've said it already, but genetic counselling team is still there in this new world of mainstreaming, and they're always there to support both professionals and the patients. So please do reach out to them. As an addition to that, we also have the charity sector, many of who now do have resources around genetic testing to support patients. The Someone Like Me campaign, which has a telephone line to support patients with breast cancer, does actually have a dedicated BRCA support group. So we often will recommend that patients reach out to that if they're looking for support for people who've been on a similar health journey. And finally, just to finish, if you feel engaged enough after today's session to take some next steps in your genomics education, then I'd encourage you to follow us on either social media, Twitter, X or LinkedIn, or sign up to our newsletter, which is the top QR code. Secondly, GeneNotes is a fantastic resource which has both an encyclopedia as well as an in-clinic resource, and the in-clinic resource has a specific oncology chapter which might be helpful to some. And also, if you fancy some more formal learning, then I'd recommend you check out the Genomics Education website, because there's lots of resources on there, from bite-sized videos right the way through to master's programmes. So thank you ever so much for listening. I'm just going to quickly flash this up before I stop sharing slides for a discussion, but we've got an evaluation which is linked to our certificates of attendance. So if you'd like a certificate to say that you've attended today, then if you just complete this evaluation, it on average, I think it takes 2.5 minutes to complete, so it's really not a long one, and it also really helps kind of steer us in terms of future sessions. So I hope that helped to answer the questions, and I'm happy to take any questions, as I know Richard is as well.
Thanks both of you. Really informative webinar, and it has generated a couple of questions in the chat. Richard has been very, very efficient and answered a couple as he's gone along, so thank you for that. But oh, and he's answered Joe. So Joe's was, is it possible to test a client who is worried that they've got no living family member who themselves weren't tested, and should they be directed to their GP? And Richard's answered that, so thank you very much.
Yeah, so sometimes we find that actually the most helpful tissue in that scenario to test is perhaps breast biopsy or breast resection tissue, which is often kept on a deceased relative for up to 30 years. So we've had scenarios like that where we might see a lady's daughter, there's an exceptionally strong family history of breast cancer, but no alive relative to test, but we can get consent and potentially perform gene panel testing on excised breast tumor tissue via the pathology lab, and that's been successful in some cases. If not, the patient themselves may meet criteria, but those criteria to test an unaffected person are very strict. So she would only qualify if there really was an exceptional family history.
Lovely, thank you. Has anybody got any questions for Helen or Richard? We've got probably about 5 minutes if anybody's got a burning question. You've stunned them into silence by the looks of this.
Use them further.
Either that, or we've just been absolutely super and answered all questions.
And I think it's the latter. Helen, Richard, if you wanted to pop your emails into the chat box, there might be some questions that people want to ask offline. We usually do that, and if I'm sure you'll be absolutely delighted to receive some questions if anybody has any. Right, it looks like we'll be able to give you 10 minutes back to grab a cup of coffee before your next meeting. So thank you very, very much. Absolutely brilliant session, and thank you for your time. And thanks everybody for joining.
Thank you guys. Thank you.
Thanks everyone. Thanks.